Okay, so anyway, we're going to talk about stem cell and platelet plasma injections, but we're going to talk about it in an office setting. All right, so basically, many of you have showed us things in the lab, and absolutely that's so important because I couldn't be where I am without people helping us in the lab. So I'm going to try and show you how we're kind of putting this into the real world as far as patients are concerned. Now, I'm a physician, but I've never met a physician who has healed a patient, because we don't heal patients. It's the cells that heal the patient, not the doctors. We can guide them along, we can do surgery, we can give supplements, we can give pharmaceuticals, but the cells are the things that do it. And this is what regenerative medicine is all about, the cells healing the patient. This is what stem cells do. Every surgery I ever done, the results have come to a conclusion because of stem cells. Now, we need to talk about platelet-rich plasma. Okay, I'm a gardener at heart, and I like to think of stem cells as the seeds, the scaffolds such as fat or other things as the soil, and platelet-rich plasma as the fertilizer. Now, when we talk about platelet-rich plasma and this whole field, the more we know, the more we don't know. So hopefully everybody's going to leave the talk today. They're going to know more, but because they know more, they're going to actually know less. Now, this is what peripheral blood looks like. We have a lot of red cells, we've got some white cells, and some platelets. Now, this is what happens when we have platelet-rich plasma. We can see here we have a large number of platelets in there. Now, what's basically found in a PRP? It's not just platelets. When we talk about platelet-rich plasma, we're talking about also having neutrophils, macrophages, and macrophages are extremely important. Fibroblasts, endothelial cells, and one of my favorites right here, a number of very primitive embryonic-like stem cells. This is going to be one of the major monumental things I think that's coming up in the next few years in clinical stem cell therapy, the very small embryonic-like stem cells. We'll talk about those in a bit. So we have the power of platelets. Obviously, we all know these insignias here are the various growth factors. A lot of growth factors we're interested in clinical orthopedics and musculoskeletal stuff. Vascular endothelial growth factor, IGF-1, insulin growth factor 1, the active form of HGH. Very important in cartilage formation, etc. Now, what are basically cytokines? Really, when we think about it, cytokines, the best way I can describe it is right here in my pocket. It's the way the cells communicate with each other. It's the body's cell phone system, so to speak, and there can be either proteins, peptides, or glycoproteins. But this is basically every condition in medicine comes down to an imbalance of cytokines, be it cardiology, be it pulmonary, be it orthopedics. It's an imbalance of cytokines, and that's what we're trying to do, balance these cytokines again. Now, cytokines basically can work in an endocrine fashion, autocrine fashion, but what we're interested in mainly in clinical entities, the paracrine fashion. That seems to be how things work the best because they affect the neighboring cells. Now, as I said, it's cellular communication. Now here we can see an inactivated platelet, and when the platelets get activated, they start looking like amoeba. They have all these various growth factors on their tips. We have vascular endothelial growth factor, SDF1, also called CXCL12, very important in calling stem cells to the area. Now, this is something that a lot of people get confused with, angiogenesis versus vasculogenesis. Angiogenesis, basically, there's pre-existing vessels that you basically increase, whereas vasculogenesis, you form new blood vessels where typically there weren't any. And that's a very important concept in regenerative medicine. We sometimes have to get blood vessels in a tendon where there's no blood vessels and things like that to get healing to occur. So you need to differentiate between the two. Now here we have what I call the cell membrane. This is the eyes and ears of the cell. This is what acts and reacts with your intracellular matrix. And we have all these various little antennae there. These are basically the receptors for the growth factors. And whichever receptors get activated, that can tell the cell what to do. And we can see here when we start getting activation, we then start getting biochemical compounds forming, we get cell division, and we get recruitment of other cells to start performing certain deeds. Now, what makes a good PRP product? Well, optimal concentration of a PRP for angiogenesis between 1.5 and 3 million platelets per microliter. Interesting enough, in the lab, but not in real life, you'll get inhibition with too high a concentration of platelets, okay? And there's no care system out there that's going to give you too high a concentration, so don't worry about it. It's not important, okay? You also have very small embryonic-like stem cells. Again, very important. Now, what else is in a good PRP product? Well, here's where we get some controversy. Some people say you don't want to have any white cells in there. Absolutely wrong. Why? Because the white cells basically are producing SDF1 or CXCL12. So crucial to the recruitment of stem cells to the area. Also, another fallacy, red blood cells. Red blood cells are not a problem in a PRP product. I'll give you some examples. People say they cause inflammation. Well, not really. If you thought red cells cause inflammation, just think of someone who had a spinal leak where they had a spinal tap and they have a pounding headache. The treatment for that is to get a blood patch. You take blood from a vein and put it right on the dura. If something was very irritating, you would not put it on your dura. So red cells don't make a difference. Actually, red cells help release nitric oxide, which is a very important aspect. Now, here we have why white cells are important. You can see here for this classic study of Jesus and Fuchs, when we have macrophages, we have stem cell motility. No macrophages, almost no motility. So again, in a PRP product, you have to have white cells to make it efficient. Now, Dr. Gusti here in Italy had some very good studies that he showed, and here's a good study. He showed us that as you had increasing numbers of growth factors, you had increasing growth of stem cells. However, he did get inhibition when he had too high a number. But again, this is more of an in vitro thing. In vivo, it doesn't seem to make any difference because you won't get it. Now, we're trying to see if we can classify the system of PRP. Dr. Mishra at Stanford has done that, and he said, okay, type 1, type 2, 3, and 4. Increased white cells or minimal white cells, activated platelets or no activated platelets, concentrations 5 times more, less than 5 times. So this maybe gives us an idea of how we can kind of say, okay, what type of PRP product to use, because there's so many different ones out there. That's why we can't have good literature analysis as to what works and what doesn't. Some studies will show it's no better than placebo, other studies show it's much better than placebo. But there's one thing that's missed in these classifications, and this is what I call type 5. And I call it a photoactivated PRP, which is a missing link. Now, we know that photoactivation is becoming more and more important in the stem cell field, especially with PRP. When we photoactivate a PRP, we cause white blood cells to produce interleukin antagonists. They go from inflammatory to anti-inflammatory, a very, very, very important aspect of things. Now, platelet activation. Tissue collagen is one of the best activators of platelets. The only reason you would ever use calcium chloride or something like that is if you're going to try and do some intravenous treatment, then you'd want to just get platelet lysate. You do not want to put platelets in a vein because you'll cause an embolus and obviously a problem. Marcaine is absolutely something we avoid like the plague. We do not use Marcaine in any of our cases because of the fact we know it's extremely toxic to cells. Now, there are some studies that show lidocaine could potentially be a little toxic, but that's in vitro only. In vivo, it does not seem to make a difference. Now, interesting also, there are systemic effects to a PRP. When we give an injection into a tendon, we're actually finding from the work of Dr. Drago at Stanford that we will get increased amounts of IGF-1, vascular endothelial growth factor, and fibroblast growth factor. These are substances that are forbidden by the World Anti-Doping Agency. So bottom line is you can do a PRP on a patient, or an athlete I should say, but you cannot give it to them intravenously because if you do, you're violating the rules of WADA. Now, what's going to be the next PRP? Well, it's an autogenous protease inhibitor concentrate. Okay, it's also called A2M. A2M is interesting. It's found in high concentrations in the blood. It's a metalloprotease inhibitor, which we find is a very bad thing for your articular cartilage and things. And it's found in pretty high concentrations in the blood, 6 milligrams per milliliter. The trick is to concentrate it. It's concentrated by certain filtration sites and things like that. Now, let's move on to stem cells. Now, basically, let's go back to some of our basics here. Stem cells, most of the stem cells we're dealing with are multipotent, not pluripotent. Pluripotent can differentiate into any type of cell. Multipotent has more of a subset of cells that it deals with. All right, so these are the various types of cells that are typically available to us. We can go all the way down the list. This one number here is just probably a bogus cell, but these are some of the other ones. But the question is, what's really practical for us in an office setting, in a private practice? Well, we'll get into that. Well, the embryonic cells, very controversial here in the United States, I suspect also here in Europe. There's a lot of ethical issues with these cells, but from a scientific point of view, why do we not want to use them? Well, potentially you could inherit a disease from that embryo. There's obviously one of the big problems we have with embryonic stem cells. They can grow unchecked and act as a tumor. Okay? However, these cells are holding a lot of interest with the U.S. Army. What they're trying to do is see if they can encapsulate these cells and have them produce increased amounts of HGH to make a super soldier. There's studies going on right now as we talk doing that. Now, next cell is an iPS cell. Now, we see Dolly sheep. Dolly really is not an iPS cell. Dolly's a clone, but the analogy is the same. Basically, one of the problems we think with iPS cells, their DNA is old. Dolly's DNA was old. That's why Dolly died of old age at a young age. And we think this may be one of the problems with iPS cells. I can't say for sure. I'm a clinician, but to me it makes sense because I think that's one of the problems we have with telomeres in general. When we look at the telomere of an embryonic cell, nice and long. Telomere of an adult cell, very short. And the shorter that telomere, the less effective that cell. I believe there's going to be a talk this afternoon on telomeres. It should be a good talk. Now, a very small embryonic-like stem cell. This has been a somewhat controversial thing because there are a number of scientists who feel it does not exist. But they're now in a very small minority, I should say. These cells do exist. They're called various names: blastomeres, stem biocells, or V cells. Basically, they're pluripotent. They may eliminate the need to manipulate or culture cells. They are probably, we're on the cusp of some really great things. And we've been using these cells for about a year now with various little studies, and we're having some pretty phenomenal results. Now, we find that certain activities will increase the cells, such as physical stress. Now, we also find certain nutraceuticals. One is, for instance, fucoidan, which is an algae from Okinawa. Now, the people in Okinawa are known to have some of the longest lives in the world. So we think maybe it's from eating fucoidan, among other things. Fucoidan, by the way, has a lot of vitamin A in it. Vitamin A, we know, is something that stimulates these cells. And also certain things decrease the cells. But let's get into some other interesting aspects of these cells. And these, again, are found in the marrow. Telomerase, they're telomerase positive, meaning they're going to keep their DNA from degrading. So a very important aspect. What else do we find? Interestingly enough, we think that these cells are related to acupuncture. We think this is how acupuncture works, because the ancient Chinese were onto something, because we find that these cells are found in these things called Bonghan channels. And we'll look at one of those channels right here, okay? Right in here. We find that these little cells, they're little specks, so to speak. When they took them out and they cultured them, they grew all 3 germ layers. That's a pretty phenomenal thing. So we think that these cells may be the reason why acupuncture works. So that's something that, again, holds a lot of interesting aspects. Now, what else do we find about these cells? They have potential for unlimited expansion. They're pluripotent, but they don't form tumors. They're your own cells. But they only get activated under stress, and they're basically an emergency stem cell supply. When we activate them in our office, we have to culture them overnight at 4, and I shouldn't say culture, that's the wrong word. We put them overnight at 4 degrees centigrade. That's what seems to turn them on, among other things. There's a common thread in all the studies that you read about these cells: 4 degrees centigrade. And they have they have a parathyroid hormone marker. And look at their size, very small compared to the other cells. What's good about that is when you give them intravenous, they can cross that blood-brain barrier. Most of your stem cells, when you're giving them intravenous, are going to get stuck in your lungs, not these guys. So basically, they have a CD90 marker, which is very similar to human mesenchymal stromal cells, and they basically can form almost any cell we want, and this is their size. So they're pretty small, but they do the job. And we know what's interesting about these cells is their surface markers undergo differences as they mature. They get different surface markers. So they're pluripotent, and they can do all 3 lineages. And again, very important, these cells seem to be very much affected by parathyroid hormone. We think these cells may hold an answer possibly for osteoporosis, because they seem to really help the osteoblast regenerate. So basically, very important aspect for the parathyroid hormone. So it's a novel disease. And now we're looking in orthopedics. We see there's a lot of studies now that parathyroid hormone seems to increase the healing of Tendons seems to increase the healing of bones. Parathyroid hormone, as you may know, is Forteo. People use that in the old days for osteoporosis. Okay, here's one of the studies that we're talking about, parathyroid hormone, chondro-regenerative therapy for injury-induced osteoarthritis. It's there, and we think what it's doing is it's stimulating these cells. That's how its mechanism of action is. And here we see it right here. Again, a little bit more of a laboratory aspect in this case. Now, what are some of the effects of these cells? Well, here's an interesting effect. One of the companies I'm working with, we've done some blood tests. Now, typically, the chromatin looks like this in most mature cells. Go to the next slide here. But we find that we're getting some cells that look more like embryonic cells, where the chromatin is wider and it can do more things. So this is a study that we're doing right now. We're doing an IRB with these cells from a company called STEM Bios. They're out of Taiwan and LA. Another company I'm working with is from Australia. So again, we talked about the parathyroid hormone. Interesting thing about these cells, this is maybe one of the most significant things of all. We think, and we know actually, because my friend in Australia, Dr. Paspalaris, who's working on these cells a lot, has transfused these cells from a child or grandchild to an adult or grandparent, as long as their blood types match. Pretty remarkable things, and the same thing you'll find when we transfuse blood from a young mouse to an old mouse. So this could be fairly revolutionary. We're still on the cusp of looking at it more, but we think that this is going to work and work well, because we're following the mouse model, and we think it's working well. He's done a series of about 100 patients. He's been able to reverse many what we thought were unreversible diseases so far. But again, it's a series of only 100 patients. So basically, what can we use in the office? Well, we have hematopoietic cells, bone marrow cells, fat cells, and very small embryonic-like stem cells. Now, when I say stem cells, it's a misnomer. We're using a symphony of cells. I never use one cell. I mean, you know, and it doesn't work that way in the clinical world. We use a symphony of cells. Now, talking about mesenchymal cells, these may not even be stem cells. You know, we used to think that they were cells until Dr. Kaplan, Arnie Kaplan, who discovered these cells, says, wait a minute, you know, I'm not sure these are really stem cells. They're important. They're probably more of an immune modulator. Okay, and this is some of his classic work. In 2011, he said, wait a minute, these are more medicinal signaling cells. That's what he liked to call MSCs, medicinal signaling cells. They secrete massive levels of bioactive agents that are immunomodulatory, and they're trophic. I mean, they can help form tissue, but they get that stem cell niche ready. I compare these guys to, you know, being from the U.S., a Navy SEAL strike team. They go into an area, they prepare it, they many times sacrifice themselves, but they let the rest of the troops get in there to be able to do the job. So that's the way I look at these cells. And basically what Dr. Kaplan now says is, hey, wait, these cells are found in almost everywhere. He feels that they're on all vessels. They start as periocytes, okay? So mesenchymal stem cells are basically periocytes. And here's what we can see here. He feels that they're active when they get an injury. He started as a periocyte, you become a regenerative mesenchymal stem cell. Immune modulation, which affects our immune system. Our immune system and stem cells go hand in hand. And then we have trophic consequences also. Now, the hematopoietic stem cells, believe it or not, are the real workers. These are the guys, through the principle of plasticity, actually do the job. And there's a lot of studies that show that. You can see here how they can morph from one type of cell to another. But more importantly, here's some good cells right here. We see that they are the engine of in vivo now that is, tissue regeneration through the secretion of certain biochemical compounds, cytokines, etc. Now, let's move on to, because there's a lot of material to cover here, let's move on to adipose cells, another favorite topic of mine. Your fat cells are a treasure trove of stem cells. We can go here and we can see all the different tissue they can form. Okay? Here's a slide, but it's a somewhat deceptive slide. The total number of stem cells is not that much greater in fat than it is in bone marrow, but this shows mesenchymal cells. So it's an important aspect to realize. Fat is very important for mesenchymal cells. Here's one of the knocks on fat as far as I'm concerned. The CD34s, which are the hematopoietic cells, they do not have a long lifespan. So that's where there's a little concern to me about using fat for regenerative purposes in orthopedics, those CD34s. But there's ways around that. This is more or less looking at SVF, where we just take the fat and break it down with an enzyme. Oops, sorry. Now, one of the best reviews you'll ever read on fat in general is my good buddy, Dr. Robert Alexander. Not the best of journals necessarily, Journal of Prolotherapy, but it's a great article on fat itself. Okay, so we do liposuction. Basically, it's very easy, it's very inexpensive, and we find it's within our guidelines of the FDA in the United States. Now, SVF in the United States, there's a lot of concern that our FDA is going to say this is no longer allowed. I believe in Europe, there's a lot of restrictions now of using enzymes. So that's a problem, and it's going to be a continuing problem. But there's reasons why I don't even want to use this if I was allowed to. Here's what the SVF looks like. This is from 60 cc's of fat. That's what we get, not very much. Here's the potential drawbacks, okay? You may be throwing away the baby with the bathwater. When you do SVF, when you break down that fat, you're throwing away possibly some of the most important stem cells in there, those V cells. They're called, in this case, Muse cells from the fat, okay? Also, you're destroying the niche. Okay, the stem cell niche is destroyed. Those cells don't work well. Now, a lot of studies in vitro show that these cells will differentiate into this and that, but in vivo, they don't seem to work all that well. Okay, so that's the problem we have with SVF. Furthermore, you're digesting away the matrix. It could damage the cells. And another important fact is it seems to damage the exosomes. And exosomes are a very important aspect here. Okay. Here's something that's going to be talked about today by myself, Lipogems. This is from your own country here in Italy. I think this is revolutionary because this gives me everything I want, and it's going to give me something that's going to work exceptionally well. The only thing I can't do with Lipogems is give it intravenously, but it wouldn't make any difference because when you give fat intravenously, most of it gets stuck in your lungs anyway. So this is a game changer, as the lecture I'm going to talk about says. Now, here's what we do. We maintain the structural integrity, and we don't violate FDA, and I believe it would not violate any of your CE here in Europe. So we'll talk a little bit about bone marrow, and then we'll end the talk here. So bone marrow, basically, we do it sort of like a hematologist in a way. Okay? I am an orthopedic surgeon. I like to use a hammer, and you can see it. The bone marrow is very hypoxic. It's about 86 degrees. Here's the problem with bone marrow. Mesenchymal stem cells diminish as we get older, and that's the big problem here. So the best place to get it is from the posterior iliac crest. Now, one of the most important aspects of getting a bone marrow is to increase your geography. The problem we have is the Gamshiti needle, which we all use to get bone marrow, is outdated. It's 50 years old, and it really was designed to get 1 or 2 cc's of bone marrow, not 60 or so. So there is now a quantum leap in getting bone marrows. This is called the Marrow Solutions needle. What we do is we take 1 cc at a time, giving me a total of 10 cc's. The real key is I don't have to centrifuge this marrow, because when you centrifuge, you throw things away. The body never intended things to be centrifuged. Remember that. This is what the needle looks like, okay? So what we're doing is we're going down, and then we're spinning up, and we're taking 1 cc at a time as a sample. So I'm getting a pristine sample, 1 cc, 1 cc, 1 cc. I'll get 10 cc's. If I take 60 cc's the old way, I have to centrifuge that, and I'm throwing away very important cells. So, and look at the bottom. It's not hollow. It is solid. So we're getting cells only from the sides. So this is a quantum leap in doing bone marrows because it's giving us tremendously high numbers of cells. And we'll just show here. Here's at Hospital for Special Surgery. They did basically multiple sticks. This is what they got in colony-forming units. I did this bone marrow, 10 cc's, no centrifugation. We beat them in colony-forming units. They did centrifugation here. So very important aspect of things. All right, so centrifugation is eliminated. Again, throwing away the baby with the bathwater. So bone marrow versus fat, you need to use them both to get the best results of all. And remember one thing, today's cutting edge is tomorrow's has been. How are we doing on time anyway? I have no idea. I'll give a few more minutes because I know one of the talks was canceled and then we'll keep going. Last thing I want to talk about is exosomes, okay? Let's see, what do you have here in Europe to deliver packages? Is it DHL? Is that your best way of delivering packages? Or FedEx? FedEx, at least in the United States, this is what I call the FedEx system of the cells. Basically what we're doing here is we're releasing little packets of biochemicals. Now this is the old way we used to think stem cells work. They just release these biochemicals, these cytokines, and they just get into the system. Well, now we know that's not the case. We now package these exosomes, or I should say the cells package them, and it's like FedEx. They get to the right place at the right time when it's needed. These exosomes are very important. Now, we found a way of getting them from the platelet-poor plasma with high-speed centrifugation. It works exceptionally well. And like I say, it's the body's FedEx system. Interestingly enough, the highest concentration of exosomes in your body, by and large, is your saliva. Hence, that's why a lot of your sublingual medicines work so well. And with that, I will stop, and we can go over questions later, but we'll go on to our next speaker, who is Dr. Andrea. Thank you so much.